Okay, everybody, I think we are just about ready to get started with our EM Hotheads event featuring the gentlemen of EM Over Easy. Thank you all for being here. Thank you to our friends from EM Over Easy for dedicating their time and talents and judgment and, vowels. And vowels, yes. There will be a donation of vowels going later today to this event. So thank you all for coming. In review, we are ACOEP RSO. I'm Spencer Heath, Vice President of ACOEP RSO, and we're very excited to have this for you today. So as this event was conceived, is that these gentlemen here, being experts in the field of emergency medicine, are going to be put on their toes. We're going to engage the sympathetic response by getting them on some progressively hotter wings, and we're going to be posing them some difficult questions, challenging questions from the world of EM. Hopefully there will be some opposing viewpoints up here. We can go a little head-to-head, get some alternative opinions, and proceed from there. So we're going to open up with a softball, Joe. Well, do you guys want to introduce yourselves before you get started? Everybody knows who you are, but let's go before that.
I'm John.
Drew.
Tanner.
And Andy.
All right.
You should have like the bluey.
Oh, the Bluey intro?
No. Please don't.
That's Drew's favorite show, I come to find out.
Yeah. Well,
The most restraint I think I've ever had you have was, I imagine that was like hard for you not to.
Stop. It's their show, not ours.
It's shared governance.
Okay.
We're all here together. So, all right, so we're going to open up with a little bit of softball for you guys. So this is a softball both in terms of the heat of the wings and the question. So an age-old question that plagues us in the emergency department, especially when selecting treatment plans, is you got a patient, they need something, and what they need. Do they need a turkey sandwich or a PB&J? What's your preferred emergency department nutritional intervention? We're going to open this up with some Hot Ones Buffalo hot sauce. Rated 2 out of 10 for heat. Should be tangy, buttery, and cayenne notes. You guys lead us off.
Tangy, buttery.
I'm supposed to eat it and then answer the question?
Yeah.
Yeah, perfect.
I'm going to take this one.
Sarah's already not excited.
I smell some butter. I mean, it's got.
Yep.
No heat. Are these working? You guys hear us okay? I'm just going to talk loud. I mean, the obvious choice is turkey. It's got actual protein in it that's going to be sustainable, but it also has really crappy cheese on it, and that can go a long way for making somebody happy. Ours don't have cheese.
Whoa.
I mean, you're getting a
Dry bread.
turkey sandwich. So they recently switched to hamburger buns as opposed to sliced. So the hamburger buns definitely keep the moisture in the bun a lot better. I would love PB&Js because I would actually consider eating the PB&J. But I mean, the other thing with PB&J is we would unintentionally get like 2% more anaphylactic reactions in the emergency department. And so then we'd be able to like just make sure everyone's up to date on their skills. Like Tanner knows firsthand that you don't give 1 to 1,000 FE via IV because it does what?
It makes your heart go super fast.
Yeah, it's like a stress test. You get MI, and then you have to go to the cath lab. Like that is not the intention of. I don't like that.
Yeah.
That sounds like more opportunities for trainees, though.
Yes, that's what PB&J all the way.
Honestly,
It sounds for
for sure.
Yeah.
Turkey. The question though is really: is it turkey or turkey deluxe? Which is the turkey sandwich, or is it the one that includes the pack of mayonnaise and mustard? Those are different. But what is this? You said something about pure protein. It's like real protein, like peanut butter isn't real protein.
No, it's not good protein.
Well, it depends on what kind of peanut butter it is. If it's like bougie peanut butter, or if it's like Smucker's.
You guys just said you don't have cheese on your turkey sandwiches. You think you have bougie peanut butter?
The only place I've worked that has a peanut butter
Velveeta
jelly
is
sandwich is it's an Uncrustable.
Right.
Okay, now that's a different story now.
Oh,
No, we have
matters now.
We have straight up. We don't have cheese on our turkey sandwiches, but we got Jif peanut butter in the
That is correct.
So not only are you causing diabetes, right, with all the sugar in it, like you're causing allergic reactions. It is perfect.
It is. Yeah.
All right. Okay.
Is that good?
I think we've sparked some debate here. I think we have some excellent opinions on both sides. So we're going to move along here. We're going to give you guys what's the fabulous sauce? Yeah, final assessment.
Yeah, good sauce.
Okay.
That's a 10 out of 10. Not a 10 out of 10.
Oh,
Don't need to
wow.
go any further.
Well, unfortunately, you're in for some hurt. So we're going to lead off with our next question. This is going to be our zesty lemon pepper from the Krabby Shack. So lemon pepper, citrusy, habanero, rated heat for 3 out of 10. So this one we're going to talk about kidney stones. So we're talking about, like, let's say a 50-year-old patient coming into the hospital they've had a kidney stone maybe one time before, not 13 times before.
Yes.
And you're choosing your initial imaging modality for this patient.
Yeah.
So a lot of literature would have us believe, like, yeah, you got to do ultrasound for these people. But other people will say, maybe that's not enough info. Maybe you need to hit them with the CT. So let's talk a little bit about that.
In honor of Krabby, I would go with ultrasound. There's a joke there.
Where?
Thanks. You'll get it.
Did you eat your main?
Sorry.
Yeah, Wayne's first answers questions. Answer second, John.
I like the flavor.
So, if they've had a CT before, ultrasound is fine. Because if you do ultrasound and you're really worried about something that you don't see, you can always get the CT later. Most of the time you can answer the question with ultrasound though, which is really, you care if they're obstructed or not. And the only reason I care about the CT the first time is because I want to make sure I know that their anatomy is all good. Once I know their anatomy is good, then I can figure out everything else with ultrasound.
Yeah, I add a little bit to that. So if they have a CAT scan of the system and they pass their kidney stone without complications, they are free to get an ultrasound until they have a complication. But if they've had complications with previous kidney stones and have a CAT scan, I sometimes lean a little more towards a CAT scan, assuming this is going to be a problem patient that I'll have to consult urology for. So I think it's the same thing as with the caveat of, have they passed it successfully with no issues, I will ultrasound that patient every time. Versus if they've had to have stent, they've had to have stent, they've had to have lithotripsy multiple times, like I might actually CAT scan that person. Because if they have a 2 centimeter stone, but I'm not, yeah.
Then why?
What do you mean?
They don't have hydro, they don't have any findings, they're not worried about anything else. You know, they're going to go see a urologist.
Because if I don't have a CT scan, we have one urologist going to ask for a KUB,
Oh,
and that
there it
is
is.
the stupidest thing to ask for in the setting of a kidney stone. So just get the damn CT scan and be done.
Yeah, I'm not going to get a CT scan. I'm going to the office.
Yeah. All right.
I mean, they're going to go to the office anyway, right? If I'm admitted to the hospital, yes. But if I'm going to send them home, why do I care? They're going to either do stent, not do the stent, do whatever it is they want to do. I don't really care.
So for you, is that a caveat? You just brought up, so if they're going to stay in the hospital, do you lean more toward CAT scan?
Well, if I'm going to put somebody in the hospital and I don't have, and the problem is, if I'm going to put you in the hospital because I have findings on ultrasound and you need to be admitted, then I don't think I can justify the admission easily without
Okay,
getting.
I see.
There's no way they're admitted to the hospital without
Yeah.
asking.
Yeah.
No way.
So for me, that's the reason.
You got a
that
KUB guy
that's-
off, it's just like, oh,
Yeah, but no.
I do know that your valid point about the ultrasound is valid, but I do not like.
Thank you for telling me twice.
I know. I know. As soon as I said that,
feels
it's a
very
valid
valid.
point.
He has
Validly
information.
valid.
I feel
It's extremely
affirmed.
valid. But I don't feel as comfortable about it a lot of times, especially in those older patients. Because I feel like older patients tend to have more pathology that could be mimicking a kidney stone that is not actually a kidney stone. And unless I can prove it's a kidney stone, I don't feel comfortable.
That's a different question.
Yeah, so I think it's important to recognize like there are reasons that you absolutely need a CT scan. So undifferentiated pain, right? So right flank pain, right lower quadrant pain, and they still have their appendix, right? It might be appendicitis. Better get 1 scan than 2 scans, particularly if the ultrasound doesn't show you what you need. Do you wait until you get a urine back that shows you significant RBCs? Now, we know that not every kidney stone has RBCs, but despite what the literature will tell you, I think it's 99.999% of clinically significant kidney stones have RBCs, right? So now we have something leading. If there's a significant infection in the urine, or the patient looks septic, they're going to get a CT scan.
True.
If they have a solitary kidney, they're
True.
going to get a CT scan.
Yep.
If they, like, history
Or
of
70.
70, they're going to get a CT scan, because now it just falls into you're old and you have abdominal pain, I don't like.
Yeah. I mean, the caveat is if you can't outlive your cancer risk, then get a CT.
Yeah, I love that. Yeah.
I mean, that is the answer.
But
Oh,
don't get a KUB.
Are you just waving or?
No, are we allowed to ask questions?
Yeah.
Oh, you just did.
Yeah.
Are you referring to as a formal ultrasound or a bedside ultrasound?
Yes.
Both.
Yes.
Depends on the shop you work at, right?
And your
Like,
skill level.
Some places you'll have ultrasound
Yeah.
during the day, but not at night.
Yeah.
And you can theoretically still do a bedside really quick to have some info, but
Yep.
are you feeling comfortable
And
with
then,
that versus
and then it also depends on your credentialing, because
Sure.
there are places that we've all worked where you could do the ultrasound but couldn't interpret the image, or you could do it for your educational reasons, but it wasn't going to be part of your clinical decision making. So it's just about how you want to work that.
Which
Like, where I
that's
currently
really
work-
hard, by the way.
Yeah.
You know, but you don't know.
Yeah. No, but like when you do it,
You can do it,
But you can't talk about it.
and you
It's
can
like-
interpret it,
It's like Fight Club.
and you have to document it.
and then,
Don't you
and
dare
then some of the
make it-
ultrasounds you can do and use, but then you can't bill for them.
Right.
So, like, I work at a shop where even if I do a gallbladder ultrasound and see gallstones, if I want to have that be a part of the bill, I have to get a formal study, because radiology, like, owns the
to see some more sweat on those brows, so we're gonna bring it along to our next heat level. This is gonna be heartbeat, lines made period. Looking at about a 5 out of 10 heat here, and we're gonna talk about EKG analysis. We've all spent a great deal of time and energy and effort, mental anguish, learning.
There's not enough sauce on
Learning STEMI. There we go. Learning STEMI mimics. Learning what constitutes an EKG emergency versus not. And we're seeing some highly respected gentlemen in the EM field now who are training AI models
It's
to.
got to take it off. It's broken.
Oh, there we go.
Somebody didn't take the
I couldn't peel it off. And I don't want to.
Malfunction. We're seeing AI models now that are being trained to identify dangerous EKGs based off a cell phone photo. So is there going to continue to be utility to invest the same amount of time and energy in learning how to manually interpret EKGs 10 years down the road?
Well,
Get your mic.
You see his wing.
Oh, you're good.
You read your damn wing.
yeah. AI-driven bastion. You're gonna rue that comment. Yeah, it's true. My answer is yes and yes. So here's the problem. I do firmly believe that AI-driven technology, EKG is a field that is rife for the thing that AI is good at, which is mass looking at things and pulling out little bits of data that are hard to see, or we could say obsequious. But nonetheless, that are hard to see. And he doesn't know that. So we pull those out. Much as our friends in the radiology field are seeing this happen with looking at mammography images. And so we see that there are things there where they catch things that we can otherwise miss, because one of the jokes that I made for the ECG people that were there earlier this morning is you get these flung at you all the time, and it's very easy to miss very subtle things. That the computer and the AI has nothing, they have no other task, that's what they're doing. The problem is that when you decrease reading of your own ECGs, you lose the skill that makes you better than the thing in the first place. And if every time you put a read in, you're adding more garbage in because you're getting poorer at reading things, you will eventually actually make the AI worse. So my answer is you actually need both, much like our radiology colleagues are doing. Everything gets 2 passes. And that is educational in both ways. It's educational for the machine, and it's educational for the person that is doing it. So that is my answer. Yes to that.
Yeah, I think AI is going to be really good at reading normal. Like, it's what they're driven. It's so much of the hard calls, that the new OMI versus NOMI, like that all requires a clinical picture. It requires somebody who understands the nuance of like early progression of diseases. I think about all the times that like we've probably all been able to catch that early MI, that early well sign. That like if they don't go to the cath lab quick, they die, and a machine might miss that because they're not looking at the right lead, they're not looking at the right patient. So that's where as long as there's a patient involved, I think we have to be involved in reading the EKGs. And if we offset that to AI to do it for us, we're going to lose the skill because you don't get good at that until you read, 1,000, 2,000, like 3. Mama 2 says over 3,000 EKGs until you're smart enough to say normal, let alone like find some minutes abnormal. So it's hard for me to think that this is the part where we're going to be able to like offload.
Well, but AI is already doing it, right? Like,
Yeah.
So the read that we get on the EKG
I was just gonna
is
say,
AI,
what's the
right?
first thing you look at when you get the EKG? I know you guys always get them with them flipped over and bent. But like, we actually look. What's the first thing you look at?
STEMI node leaders to say STEMI.
What does it say on there?
I usually look and say, is the computer stupid today or not? Oh, look, the computer's stupid.
But there's been good
Yeah.
studies, including one that was recently released like the end of last year, that looked at if the EKG, the computer interpretation of EKG says normal sinus rhythm,
Yep.
right? And there's no other abnormalities. There is.
Right.
It does not have to be seen by an emergency medicine physician in a quick sequential time period. So what happens, right, is almost every department says it's 10 minutes. EKG to read, and then so just all day long, these EKGs are flying in front of your face. Tricks. So we can just say anything that says normal can go into a pile, and at some point on that shift or that day, there's somebody, the department director who does nothing else,
Yes.
can like sit and like flip through and read the studies, and then anything else still needs to be read right away. Because what the computer algorithm is looking for, right, it is highly specific for normal. So that it will read abnormal as lots of things that are normal, right? And then it's our job to tease out, is it really abnormal or not?
Okay.
Okay.
All right. So what do we think of the sauce, gentlemen? How was period?
Yeah,
Delightful.
Yeah.
Honestly, so far they are pretty tasty.
And heat level?
Yeah.
We smoke it? No, we good? Okay.
I wouldn't have given
Touch
that.
my eyes.
I'd give that like a
Well, you're all giving us that gentle tingle too, so we appreciate that. All right, so now we're going to take it a step up with Seed Ranch Hot Thai Green Hot Sauce. This is one of my personal favorites. So for this question, we're going to talk about unions in emergency medicine. Are we moving toward a union-based future? Recent ACEP survey demonstrated that 80% of EM attendings are, quote, union curious, which is just a fantastic term. So is the broader implementation of unions in the EM job market, is it likely to have the pitched or desired effects of protecting EM physician jobs, improving compensation, improving job satisfaction, et cetera? Where do we land on this, gentlemen?
This is not my favorite.
I got to get in front of the top. I forgot you need the
I like the
sauce
flavor.
Nazi.
Herbaceous.
It's
Is
a little
that
hot,
Swahili
I like
for
it.
nasty? There is a radish on there, and it tastes like I'm eating the dirt that is holding that radish. I've not had a sip of water yet, and I only want water to get rid of this taste.
Not bad.
That's allowed.
A little spicier. It's
Really? You didn't get this spice through the flavor?
No, the issue is I used my napkin to rub my eye and I got some of it.
Oh, man. All right, so
he had said at the beginning, don't rub my
I
eye.
know.
Dr. Lil is very upset by
All we get
unions.
reminded
She's
is-
literally crying.
So
I'm gonna rue that moment.
I'm going to answer this question for you. I think you will see unions take over residency programs and at some point take over some attending shops. I see this happening in maybe university hospitals where they already have a big issue with non-competes and some really unfair payment structures.
Can't have non-competes anymore. That got
Yeah,
shut
yeah.
down.
Yeah. But I see this in the future of most places with residencies. Because if you look at places that have residencies that have it, not that it's been successful maybe for everybody involved, but overall, like residents, appear happier. They've been able to get rid of some unsafe work environments. And actually, I think the bigger issue is that from a GME perspective, EM isn't driving the bus for these unions. It's actually surgery, ortho, these surgical subspecialties who chronically just tell their residents to lie or tell them to not be truthful on surveys and not be realistic with their hours that are expected to be worked. And that's where unions, I think, are doing the most work. And we'll get some back end for that. But
So EM's along for the ride.
I think we're along for the ride.
Hell no.
You don't think so?
No. So here's what I think. I think that EM docs are inherently motivated to be really good at emergency medicine and suck at everything else in life, including advocating for their own careers. And so no way in hell is this happening. Mic drop. Next question. Let's
Can't confirm my suck at everything else.
I would argue those points are exactly why it will happen, because it'll happen to us
Right.
Yeah.
rather than us fighting it.
Yeah.
Okay.
Fair enough. My take on this is unions are an inflection point. I don't think unions are the actual end goal. I think what you're seeing through unionization is actually more a frustration of physicians at all levels about the concept of having lost control of medicine to corporate or administrative practices. And I think this is a mechanism for gaining back a sense of control over that, but it is merely a symptom of the underlying disease. And I think one of two things will happen. Either the physicians will be put down in the uprising and we will just continue to provide patient care in whatever manner we're allowed to do so, or we will actually take over again the practice of medicine and actually drive that forward. So those are the two. You can either live to a maniacal overlord or have to eat that horrible sauce, which you should never ever try. It's not hot at all. It's just
Yeah,
dirt.
that's not going to be the one you're going to put back on your wings when we're done.
Oh,
The
God.
last one you're not going to.
No, never.
All right, well, let's cleanse the palate then. I mean, let's move
Okay.
on. Let's get Dr. Casey something he can enjoy.
Yeah.
So we're moving on to some Tierfing's Curse. I have not personally sampled this one yet. This is going to be tart with hints of ginger, scorpion pepper. So the topic is asymptomatic bacteriuria. So I think if we had some of our FM colleagues in here, this would actually be a pretty strong debate. So
I think.
the patient comes in the emergency department, they got a few white cells in their urine, no reds. plus minus nitrites, absolutely no symptoms whatsoever. They came in because their pinky finger hurt 3 days ago, and they just felt like getting out of the house for a minute. And I mean, to treat or not to treat, because I believe our FM colleagues would say, guys, what are you doing?
So can we back that up a little? Why did we get a urine on the patient that came in with a stubbed pinky?
Nursing standing delegated order set.
No, they only
got
get
it coming in the door.
EKGs on those patients.
Coming in the
They
door.
don't
The patient came in with the urine already peed.
Already
And they said, "What do I got to do with this?"
this.
I was told to bring this and this live snake.
So this is an easy answer. It's absolutely not.
Yeah, I would argue we're already doing this. So the difference between us and FM, in my opinion, is we're seeing the patient in real time with, like, if it is truly asymptomatic, I don't think we are treating that. In fact, there's lots of, say, pregnant females come in and we automatically get a urine on them, and if they have even like one potential half-circulating bacteria in their urine, it goes for culture, but we're not putting I don't know what these guys are doing. I'm not putting every single one of those on antibiotics. So, yeah, I mean, you have to, like, what's the patient in front of you, assess them, see. However, I do think that in real time, there are a lot more symptoms that portend urinary tract infection than we necessarily give credit to. And I would say one of the best things you can do, that we have to do, is review cultures. So you see all the patients that come in with maybe symptoms, maybe not symptoms, that are culture positive to determine, are they on the right antibiotic, or do they need an antibiotic when they weren't already on them?
Yeah.
I didn't need my wing, so I'm sorry.
Oh, okay.
I violated the free
I was
code.
going to comment
So
on
fired
that.
up.
You know what?
First of all, much better. You redeemed yourself. That was delightful, and I could enjoy it.
Punishment.
Here's what I say, and I kind of hinge a little bit of what you're saying, but I actually, because you wanted a pro con, I'm going to be all in. I'm going to say treat it. Because here's my thing. You showed up at the ED. You were not asymptomatic.
By definition.
By definition. And I ain't got the time or the patience to sort out your medical history. I don't have the 50 medical assistants.
Oh, you
who
got
are
the
trying
patience.
to find.
Don't
I
you
got
your
it.
residents are for?
Well,
Oh,
Snap.
yes.
Snap.
Says the guy that doesn't have it. Of course, I'm like, no. So here's the thing with it, right? I don't have time for follow-up. So this is where I agree with you. If I'm working them up for ACS, and they got an incidental urinalysis because they happen to pee and somebody put the order in, and it's asymptomatic, and I confirm they don't have any symptoms, I don't care about that. I'll just say it was an asymptomatic positive test followed through PCP. But if they came in with any of the myriad of things that you talked about, right, like they just came for nausea, or they just didn't feel well, or whatever, oftentimes that is they are there. They came for a reason. I'm going to treat it. Their follow-up is horrible. It's a disjointed healthcare system. I think the potential risk of a low dose of a usable, easy, common antibiotic is probably far outweighed by the potential misses of this. Where I will say I go off piste is if I look up and they have more than 3 allergies, it's a hard no. I don't care what they are. It is immediately, I'm going to send that for culture. That's asymptomatic bacteria. Yeah, for sure, 100%.
One of my roommates from medical school ended up going into infectious disease, and he despises urinalysis.
Yeah.
He says they're garbage. Most of the time it's nothing. He only cares about cultures, and even then he's like, It's like, so, I mean, he has hammered home to me that it's most of the time pointless for the urinalysis anyways, let alone asymptomatic. So for me, I'm like, all right, if he's good with it, I'm good with it.
So let me ask a follow-up question because we're doing great for time. So let me just say, I've seen this happen a few times. You got a patient who has ESBL E. coli, like, still completely asymptomatic. You know, it was an incidentaloма on their workup. Got cultured after they'd already gone home. They're allergic to everything PO, or it's not susceptible to everything PO you could give. I've seen these patients get called back into the hospital, PICC line placement, outpatient antibiotics. I mean, are we doing them a service with that? Are we doing antibiotics resistance as a service with that?
If they're asymptomatic, they're not febrile, all that kind of stuff, no, I'm not treating them.
That's it.
But we make the call back to see how they're doing, what they're up to.
Yeah.
If they have symptoms of any kind or there are concerns, then absolutely.
I recently had one of these. It was a guy who's been in and out of the hospital multiple times, and now we have try to decrease readmission. So I called ID. I said, hey, I got this guy. He's like, he is always going to have ESBL in his bladder. He will have it until the day he dies. Does he have a fever? Is he tachycardic? Is his blood pressure low? No. Send him home.
Yep.
And so it's the I think we have to make better decisions than what is a urine check.
I mean, it's like, are we pulling the urine off the dirty Foley that's been in there for 6 months?
Yeah.
On the patient that has no complaints? Like, yeah, like it's colonized pool. Or are we putting a new Foley catheter in and then drawing, like what?
Yeah, did they come in with I brought a sample from home that they put in a Dixie cup? People do those things. Like,
Yes, they do.
hey, I got my urine sample, and it's like, it's in a Ziploc bag with nuts in it. Like,
I mean,
you just feel the need to be in the car?
My mind when you said nuts went to a
Yeah, I was going to say.
I put it there for a reason.
Yeah.
To see where these people
Yeah,
are.
yeah.
So, yeah.
Like, when you put your nuts in yeah, great.
Not my nuts, but
Full, full circle on this conversation is basically, this is reiterating, be deliberate with what you're ordering. Don't just order something random because it might help me, it might not. It's like, no, if you actually think that you need a urine, order it. If you don't, then don't order it.
yeah, ESBL, every stupid bacteria lives here. And they're all bad. They are all bad.
You're looking a little red. You
Yeah,
get
I know.
Yeah.
I scratched my head instead of
You're
rubbing my
It's also
eyes.
rationing his water,
Yeah.
So can I ask a follow-up question? So
Please.
we're on time. So I'm curious, my esteemed colleagues up here. So one of the biggest frustrations about urines is getting urine on a pediatric patient still in a diaper. How do you do it?
I don't.
ask the nurse.
See what you do is you grab it from their ankles.
It's like, oh my God, she's got a real tip here.
There was a study a couple years ago that if you hold the kid up, right?
Yeah, that's not what
And then you like tap on their suprapubic sub.
Careful with your words, Drew.
Yep.
Yeah.
If you tap them long enough, like eventually they pee.
Well, if you hold anybody upside down by their legs and tap them long enough, I'm sure they would pee.
I would too.
Not
We're gonna
unique
try it
to
right here.
yeah, not unique to the patient population.
That would make me hold it more. Like,
Yeah.
don't touch me while I'm
Little kids
No.
don't have that indication. Right.
And so
Yeah, they have
here's the
to
question, right? Like, so I think the reason this gets so sticky is because we often are looking to it as the last bastion of how to get them out of our ER.
Yeah.
Right? If we just knew this, we could wrap it up, and we feel like our workup is incomplete. But here's the thing: this is where our family medicine colleagues actually beat us a little bit on this. Is they're okay with, yeah, my office closes at 5. You're going to go home, and then you just check back in tomorrow and let me know how you're doing. And if you get worse before then, there's this awesome place you can go to.
Then it's guaranteed to start you on
And
antibiotics.
so it's kind of the same thing, right? There's no reason that we can't be like, you know what? It seems like your kid's really tired and really grumpy, and this seems like a lot of things. And this, if you have a shared decision-making discussion with parents about like, based on your symptoms, they were, holding their wee-wee and complaining in pain every time. I think it's probably a UTI, and I think we should start them, and then we can do this. Or, it's probably a virus, and this probably isn't going to show anything. Rational people will tell you what they want to do. I mean, we can wait here until the kid pees, or I can turn them upside down and thump them. But so, a lot of shared decision-making solves a lot of problems, is all I'm saying. As long as people know what it is you're doing and why you're doing it.
If you're looking for a tip, if you're trying to do the little pediatric straight cath, little boys don't like that nice hard tube being shoved in their penis.
What?
And so you can take an 18 gauge angio that's 2 inches.
Remove the needle first.
I was about to say that. So you remove the needle, you attach the angio catheter to a 5 ml syringe, insert it into the bladder, and irritate it, and then pull back. And you're good to go.
I just put some cotton in the diaper, and eventually you can squeeze that out. You get a little bit of leukosterase, and just know it's going to happen, and it's fine. Like, it's all good.
It's all good.
All right.
Sticking cat.
Now I want to make sure I make the offer. I think you guys look like you're all doing pretty well. Maybe Dr. Little having rubbed his face and eyes and ears and other orifices. I want to make sure I make the offer. There are milkshakes here. You do have a nuclear option should you choose to utilize it.
I'll go for it.
Okay, well this next one's a bit of a step down. This is Los Calientes.
This is a step down.
Los Calientes, perfect. Yes, this is a little break. This is our little interval here. So the question to go with this one is caffeine intake, on shift, off shift. Coffee's been the mainstay of healthcare providers for a long, long time. And more recently, us youngins, we're coming in and we're talking about Celsius, rain, C4, all these terms. What are we doing? These colorful cans. brightly colored. How are we feeling about this? What do you guys?
I got a heat for a second.
Yeah.
Well, my go-to has always been Diet Coke. It will always be Diet Coke. I have tried these other things that you guys do. What the hell is wrong with you?
I was going to say, your caffeine content, your Diet Coke is cute.
Yeah.
It's cute. I think that's caffeine.
But no, so I had to drive
Right,
home. I had to do a 16-hour drive home in a blizzard with my kids a couple years ago. And I was like, oh. And I texted a friend like, you gotta have it. Go get a Red Bull. So I bought 2 Red Bulls. I was in freaking I was in SVT for 3 days. What the hell?
And we say Red Bull what? You mean melatonin?
Yeah. So I got 2 Red Bulls, and then I remember on shift once, one of our residents loves Celsius, and she had left some around the department. And I was like I was on night shift 4 to 4, and I had 7 hours left. I was like, what the heck? I'll try one of these. Never again. Like, I couldn't sleep for like a day and a half.
It's all tolerant.
Yeah.
Love it.
No, that's
Acaphylaxis.
no. So for me, if I have to drink more than 3 12-ounce Diet Cokes in a 24-hour period, I have a problem. I need to reset my Coke. I know that's rookie numbers compared to other people at the table. But there are other things you can do to be to be ready and energized. It's turn your phone off, actually take a nap, read a book. Like there's other things you can do to like rest, so you can be awake and on shift. So do some of that stuff will be easier. I promise.
If you're making me pick one, it's coffee, no doubt. Slam dunk.
Yeah.
It tastes good. It's delightful. You can flavor it different ways if you want. It's accessible at every hospital in the entire world.
Well,
It's not necessarily the best at every hospital in the entire world,
I come from the Folgers machine, but
but it also comes in decaf options, which is nice. Like after midnight on a night shift, I don't drink any more caffeine because I need to sleep when I get home. But I do still like the coffee, like smell, the flavor. There's something nice about having that just warm cup next to you.
Yeah, I'm all about caffeine early in the shift is coffee for me. I don't do any of those other things. Like the only good thing about Celsius is that maybe people start understanding what that means when they get a number on the temperature, like Fahrenheit. So I would argue, kind of like Tanner had, I've actually actively worked to decrease my caffeine consumption on shift. I used to go grab Diet Cokes, and I realized the reason I'm grabbing Diet Cokes is actually because I like the carbonation, not because there's not enough caffeine in Diet Coke to touch me. So sparkling water of another thing. I spindrift. It makes me feel like I'm drinking an IPA on shift, and it puts me in a happy mood. There's no alcohol in it, so it's fine.
Unless you get the alcohol ones.
right.
Yeah, well, unless, but
Yeah, don't do that.
I don't.
Don't
I
do
don't.
that.
I don't. Yeah, no.
You should do it after.
Yeah,
because
for sure.
They're
100%.
They're so good.
Coffee,
Yeah.
all the way. Coffee.
Yeah. The number of people who thought they grabbed energy drinks and then realized that they had actually grabbed an alcoholic beverage is quite more funny than one would think.
Spindrift is not an energy drink. There's no caffeine in it.
Really,
It is.
really is
No.
not. Yeah, I'm coffee all the way. Energy drinks. So there's a couple of problems with it for me. For one, I don't love change, and it took me a long time to get to liking coffee. I mean, Tanner, you said coffee tastes good. It does not. It tastes bad. We all know it, but you develop, right? You develop, and then it's more subtle. It's like there's no 8-month-old. It's like whiskey. But by the time we're 24, we're whiskey. Yeah. So I think there's that. I also like that coffee. You're exactly right. The variability. You can make it iced coffee. You can bougie it up. You can make mochas with hot chocolate. You can do all kinds of fancy things. Energy drinks. The problem is, I find that I find a drink I like, and then I can never find it. They only sell it at one Speedway, which is 8 miles out of the way, or they didn't get a shipment, or they didn't do whatever. And I find that loyalty just kills me there. So I don't. Coffee is just it's whatever it is, and when it's there it is. And so coffee all the way. None of this pre-pepping energy drink nonsense.
Do you understand what they're talking about? Coffee's not good.
I don't.
It's a process. It's an art. It's the nectar of the gods. It's
That
a thing
part
of
is all
beauty.
good. That part is all good. Coffee itself tastes like burnt beans.
We're coming back to the concept of tolerance.
Because it is burnt beans. I like it. I drink coffee, but come on.
You're not ruining it properly.
You're not ruining your coffee. Right. You're not adulterating your coffee properly. Yeah.
Well, I'll just say that the culture in our residency program, we're pretty far from the area where we can spend our residency food allocation. So what it boils down to weekly for us is that we go over to the little cafe and we say, hey, can I get a case of Celsius and 3 more Celsius?
Nice.
And that gets me right up to that limit. So
Nice.
All right, gentlemen. So that was our lucid interval. So here we come. As I tell my patients often, I'm not a cruel man, but here comes our last two difficult questions and our very difficult hot sauces. I wouldn't put you through anything I haven't done myself, and this is straight up not a good time. So I'm sorry. This doesn't come with a level.
What's the boneless? What's the boneless? Okay, this is the boneless. Oh, there. Okay.
Yeah. So.
Fiery, all natural. That's
Yeah, so this is, I'm pretty opposed to extract sauces. I'm not a fan of extract sauces, so I won't do anything like that here. But this is a very intense bomb evolution. So we're talking about direct versus video laryngoscopy, and so there's a caveat to this question. So we're really talking about in the training sphere. So with your learners, with any learners, like obviously direct laryngoscopy has been the mainstay for a long time.
No, it's not freaking way you come on. I'll be with you.
There we go. We love to see it.
with this.
Get past Tanner's eyes on the leg. There we go. So direct laryngoscopy has been the mainstay for a long time, rightfully so.
No, it's not.
Video laryngoscopy is demonstrating superiority for new learners, for experienced intubators, like all levels of operators. At what point do we accept that it is available enough, common enough, reproducible enough, fail-safe enough, that is there ever going to come a time where we say, this is the standard now, we don't need to continue?
The time is now. It is the standard.
No, let's play 10 years ago and you start first with this question. That's why No, I mean, it is video. The question actually is not DL versus VL. The question should be, what is your VL approach, right? Because not all VLs made the same. It used to be that it was a hyperangulated blade and that was it. So it was a glide scope or it was a CMAC and they were hyperangulated. And so there's an anatomy question with that. But now, VL it's VL with a hyperangulated blade, it's VL with a MAC 3, it's VL with a MAC 4. So, just like anything, you pick your approach, right? I mean, it's sweaty. It's all right. And so,
Why did you ask us to do this?
so as I tell residents for myself, the thing you need to do is like, I love a match race video, and that's what I do, and that's what I do every time, and then you know why you change to the other. Somebody in the audience right now is thinking like, well, what if it fails? What if you get gunk on the end of your, what if a 747 crashed into your hospital, right? Like, cool stuff, right? Like, just, sorry. It's a passion point for me.
Yeah.
I got triggered.
If it fails,
okay?
just give me a light still in the other room.
I'm good, I promise.
Yeah.
I'm not crying, I promise. It's this way. Yeah, I think that I still remember the three of us sitting across from, what was it? Was it Howie Mell at ACEP in, right, 18 or 19? And he was like, he was the other way. He's like, direct is the best, and it was just like, why would you not just have a picture on the end of the thing you're good at? And so I think that's always the question is going to be.
Yeah.
I think there are indications for direct laryngoscopy, but they are after a failed video attempt. And so you need to learn that skill, but like as Drew mentioned, have a direct blade with a camera on the end, which doesn't matter which one, McGrath, Vitescope, they all have it now. But let's say you decide to go direct only, and then you don't get the airway and the patient dies before you can put a video. I can tell you that will come up in court, where they'll be like, you had a video device in the room and elected to use a low-tech technology and had a bad outcome with the patient. Or you put video in and couldn't get the airway, you used the best technology available and couldn't succeed. Okay, we'll give you a pass because you used the best. So I think that's also like we have the same issue with ultrasound and non-ultrasound for central lines. It's like, I know how to put in a fem line with that one. I don't like to. I'd rather know exactly where my needle is going. I'd rather not lacerate the femoral artery as I go in. I'd rather not cut their nerves so they get tingling in their toe. Like all those.
Yeah, but come on, how cool is it when like the resident can't get the fem
Oh no, there's no doubt that like
just walk in there and drop.
You could just be like, oh,
I mean,
you with the machine couldn't get it.
It's kind of a
boom,
badass,
it's
it's a
in.
badass move.
But if I'm going to place one when I'm by myself without a learner where I can like, I don't know, be a bully with, I'd rather do it with video because I know exactly where it's going.
Does anyone else have that thing like when you eat really spicy stuff, you feel like your eardrums are sweating?
Yeah.
I don't know why, but that's what I feel.
Ellen, thank you for the. I'm gonna like thank you for this. Thank you for the napkin.
I'm up here sniffing like it's a pancake. I like the idea of both. I like the ones where you can do the direct and have a video screen and I can watch you. I think you do need to learn both ways. I think it's important in emergency medicine because we forget that in our emergency departments, video is the standard of care as it should be. But many of you will choose to do mission trips or work in underserved or underpopulated areas, or you'll be in the community, and you want to have access to these tools. And I think you should know how to do.
Buy your own video laryngoscope. Like,
I'm not flying that on a plane.
why you flew penises on a plane to come out? All these people.
I mean, if on a video laryngoscope on a plane, you will get pulled over by TSA, and they will assume it's a gun. And then when you attempt to take it out, they will assume you're pulling a gun out of a box. So
Right.
They did the same thing with penises. So on behalf of ACOEP RSO, I do want to thank you for your penises. Sorry. You have facilitated our learning
Me and
greatly.
my penises are happy to serve.
All right, so we do have one final sauce. I will join you guys for this one. I, again, wouldn't ask you to do anything. I would. These wings are coming unsauced. They will be sauced at the table in the last dab tradition. This is the latest of the last dab line. This is the last dab experience. 91% pepper X, a new hybrid strain of pepper. They're pretty gnarly. So. We have a variety of milkshakes. We got chocolate, vanilla, let's see, caramel, Oreo, I think. So don't know what's what. So swap amongst yourselves.
yes, it's just chocolate.
Miss Turley, may I have a wing as well, please? Thank you.
Got a, I don't know, chocolate.
So the question on the table here for this one, gentlemen, is not about broader APP practice within EM, because that's going to be outside of our scope here. The question is, and I actually don't know what the practice laws are where you guys are working, but in Texas at least we don't have.
No, we have to use this one, right?
Last dab.
Oh,
yeah.
sorry, you took it.
So in Texas at least we don't have independent APP practice, but what we do have is APPs who are seeing and dispoing patients independently.
Both sides?
And then, very generous, very generous. What we do have are APP colleagues who are seeing and disposing patients independently. Oh my God.
This guy seems to know what he's talking about, and he's saying that. Oh my gosh.
We'll take a moment.
Hot time group was good in case he disagreed with that.
We'll take a moment and we'll scrutinize everybody's dabbing technique here. We'll get back to the question.
Tanner put as little on as possible.
Maybe just like a little.
Wow.
Don't put it on your fingers, you'll put it in your eye.
That's why I put it on the pinky.
Yeah,
She's talking to
yeah.
me.
I'm talking to Andy.
It has no flavor. It's just hot.
Huh.
Like it does. There's nothing on the tongue. It's all in the like. This is.
I mean, I did say 91% pepper X, so it's kind of the Everclear of hot sauce.
Okay.
So-
one of my funniest
Andy's
things
like
before
praying.
I take this.
No,
I
I'm
will go
visualizing
take
you in the wing.
Yeah. One of the funniest things ever was this, but if any of you watch Medea, they did this Medea riff, where she holds up and she says, if you ever need evidence of systemic racism, it's Everclear. She said you hold up most bottles and it says things like, danger may cause problems with babies, and you hold up one Everclear and it says, the shit's flammable. That's what it actually says on it, flammable. It's really flammable. So anyway, dear God.
So the question on the table is, in some places we have our APP colleagues who are seeing and dispoing patients independently. And then the attending is being asked to sign an attestation that says, I didn't see this patient, wasn't told about this patient, didn't know they were in the department, but I was available should I have been consulted by the APP. Is that an attestation that EM physicians should be signing?
Nope.
Do I have to?
Yes.
Yeah.
So in your particular practice, that is something you're being asked to
Yeah, and so it can vary state by state. There are states that require you to, as a supervising physician. That is really hot and has no flavor.
There's no flavor. It's
But I still like it better than the last one.
Why? The last one or the?
No, that Dove thing. That was just hot and it has some flavor. This is stupid. This why don't ever. Sorry. No,
Yeah, hot but stupid. That's the vibe I go for too.
Yeah.
So.
Right
get there.
Yeah. So here's the thing. What you have to be really clear about is what you are signing and what your note actually says. And for most people, it says some combination of. In some places, just simply like note sign for protocol. Some people actually put, I didn't see the patient or participate directly in their care. I didn't review the chart. Some people put, I reviewed or I discussed. And I think you need to document what you actually did if you are required. But I think if you are not required by hospital policy, and if you are, you should work to change it, or by whomever you work for by their policy, you shouldn't have to. If an APP is independently allowed to evaluate and treat patients, independent practice, whether you believe that to be a good thing or not, is independent practice. If it is a co-management practice, if that is the standard of care, then not only should you actually be reading the charts, but you should actually be attending the patients and in discussion of the care of the patient. And that is where I stand on that. So a lot of people do it because they have to, not because it's the right thing to do.
I worked at both places. I was a travel doctor for 5.5 years. I worked at different shops, and some places I did, some places I didn't. I even worked at one place where I had to sign their charts for the patients that got admitted, but not for the ones they sent home, which always seemed backwards to me. It's like, oh, you think this patient's sick enough they need to be in the hospital that's being seen by another doctor, but the ones that you're just sending home to do, like, that's the one that I don't have to sign? All right, whatever.
Yeah.
But, like, yeah, I mean, I agree with that. Like, you do what you have to do. I do agree with documenting, like, if you are participating, make sure you document it. If you're not, document it that way. But this is also getting hotter the longer I'm sitting here.
Same.
Like, it literally had like it was like just hanging out in third gear for a while, and all of a sudden it was like, oh, you're still here.
When you said it was like a synthetic mutation, is it like a genetic mutation where the molecules are getting together in my mouth and they're like, he partying?
It's just straight up Mendelian genetics, man. It's just crossbreeding.
So I work at a place where I have to sign the charts. When I started there with our old EMR, my signature was, it was just I would click on the chart, and then our system's auto signature was, I was available for the patient's care, read the chart, and agree with all management. And that like scared the crap out of me because I was reading charts and I'm like, I disagree with this statement. But now that we've gone to Epic, Epic allows me to sign a note. My note, when I don't see them, is very straightforward. It says, I was available for consultation, but was not consulted by the advanced practice provider. All details related to the care and outcomes of this patient should be given back, like should be sent back to the APP for the questioning. Like that, and it really, unfortunately, it makes some of the APPs mad because it makes my group mad because now they can't bill for the entire 100% of the visit because my cosign's accurate. Yeah. But at some point, you've got to take a stand on what do you want, what's the risk you're willing to take, and are you willing to lie or like maybe deceive the medical system in the name of something that isn't, in my opinion, probably isn't safe.
Short answer, don't.
Yeah.
I like, there's a place I work with the APPs actually put in their note that my attending physician was available should they have been needed, but were not directly participating in care. And then all I did was sign. Like I co-signed orders at nurse's place. Like, so I actually didn't say anything. I just signed the chart. I have no problem with my name being on the chart. I was the physician of record in the emergency department, but it says by them that I didn't participate in care as opposed to me having to say I didn't participate in care. So that to me actually felt like a really good compromise to go, you have to do it, but really they're taking the onus on it.
And that may be an easy one that you can use to kind of leverage for your hospital. If you have to do it, you can say, hey, why don't we just have the APPs write this?
Yeah.
And it kind of makes it a little more. Cool.
All right, well, gentlemen, thank you for suffering here.
Yes,
This
it keeps getting
is suffering for our pleasure. Give it up for you over these guys. Would, gentlemen, can you indicate each of you what your preference was among the available sauces?
I like the lemon one. I did like the one that John hates because it had some nice Thai flavor.
Where?
right there. It says it.
Thai bud?
But it's a coffee thing. I like the taste of earth.
Not surprising.
I mean, really,
the Idaho thing.
do I have to say anything else to convince you of the flavor of that sauce? I like the taste of earth. This is actually.
Yeah, that's a good spice.
Cheers.
Yeah, it had the heat, but the flavor was.
But also
that one was
Really
good.
like that.
heartbeat hot.
Yeah.
It was also
The
really
one you
hot.
gave me extra was good.
Honestly, I was pretty surprised that most of them were good, except for those last two were.
Yeah, and this, the bomb is the crap.
Yeah,
Yeah.
yeah. You don't eat those for fun. That's they're not for the flavor.
That is what we call in the South just mean hot. It's
It
like
says,
when-
warning, this sauce is extremely hot. Keep out of the reach of children.
and we put it in
Consume
a-
one drop at a time.
Wait a minute.
Because they're dipping the entire thing inside of it. Fire, 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 fire.
All right. Well, that's all we have for you, gentlemen.
Yeah.